I am a neurorehabilitation physician with particular emphasis on patients who have suffered a traumatic brain injury or stroke. And my sort of typical day when I'm on service is I work at Harborview on the consult service, and so we see patients all over the hospital who have had some sort of brain injury or bleeding or clotting stroke. Essentially, that's our core group. And I also have a clinic, so I see patients on the outpatient side, and so it's really great because I get to start with the patients in the intensive care unit and follow them through their hospitalization, and actually then end up seeing them in clinic and perhaps for years beyond that. So that's just a really great, I think, arrangement. And on the side, I do concussion work with the National Football League, and so I'm one of the sideline concussion doctors. Yeah, so a traumatic brain injury is either microscopic or macroscopic. So sometimes you can't see it at all because it's on a microscopic level, and sometimes it's very obvious. It results from what we call an acceleration-deceleration movement. So it's not that anyone has to hit your head, it's just that your head has to be moving and then stop, typically suddenly. And because your brain is a soft organ that's inside of a hard shell, your skull, that movement inside can cause the injury if it's robust enough. And so we think about concussions as a kind of traumatic brain injury, all the way to injuries, really bad car accidents that put people in coma. There's a whole spectrum there. Stroke is when part of your brain doesn't get enough oxygen, typically, or blood supply, and so that can be because part of your brain is bleeding, the blood vessels rupture, they burst and they start to bleed, or because they get there's a clot or there's something that gets stuck in the vessel, and that stops the circulation. So I decided to specialize in both because I really enjoy neuroscience, and I think the brain is absolutely fascinating. And these populations in the hospital tend to come to rehab hospitals, or they often need rehab because they're often disabled. And so it made sense to me to focus on everyone who has a brain injury of one sort or another. I think I went into rehab because I enjoy the continuity, so I really enjoy being with the family and the patient, at the most acute and really scariest part of the journey, which is when they're first injured, and then watching patients very slowly recover over time. And this can be days, it can be weeks, it's often months if the injury is severe enough. Then again, following them out when they get out and try to get reintegrated into society. And I think that continuum is really fascinating to watch and to be a part of and to celebrate with families. And so the process of recovery, I think, is the most fulfilling part of this job. The Coma Recovery Scale is the gold standard internationally for evaluating patients at the bedside who have a disorder of consciousness. And so that starts at coma, and then the next level is vegetative state, then minimally conscious state, and then you move into consciousness. So there's a spectrum there, and there is a very specific exam that we do as the standard of care to assess these patients to determine where they are on that scale. The original CRS, we call it, Coma Recovery Scale, is very long. It takes about 40 minutes to administer. And because of that, it isn't as widely utilized in the hospital and the healthcare setting as it could or should be. And so because I am a Boston transplant, I was able to work with the team in Boston that I'd been working with before when I came over to Washington, and we continued to work together to develop essentially a shortened version called the CRS Fast that takes about 7 minutes to administer. And so our hope is that this wonderful gold standard of clinical care, now that it's sort of shrunken down into a much more efficient vehicle, is more widely used, again, not only in this country, but internationally, just as the original CRS is used. So in my role with the NFL, I'm not actually an educator formally. I'm more a clinician, and so I'm at the side of the field, the sidelines, evaluating the players, and I try to sneak in a little bit of education because they're kids often, they're very young, and they don't understand, I think, the gravity of having even a concussion and how that can affect them down the line. So sort of informally I get to educate, but very quickly and very little. Outside of the actual field, then I'm able to educate more formally through lectures to the medical students and the broader community. And so I think with the NFL we did there's a video that's out there on the web and discusses what the NFL has done to improve the concussion protocols. So I think that's sort of a way to educate the public, but it didn't go quite as deep as I would have liked. So I try to find multiple avenues to educate everyone.
Yeah. And so when you're on the sidelines, like, are you there during games with the football players?
Yes, from beginning to end.
Ooh, okay, so what's your favorite team to follow?
I don't like football at all.
I was like,
believe it or not.
Okay, so how did you get into working with the NFL then?
So my chairman at the time, many years ago in Boston, he was one of these sideline doctors, and he had to step down from the position, and so he essentially asked me, are you interested in doing this? And I thought, well, sure. I don't like football, but it seems like an interesting opportunity. And in fact, it's been really eye-opening, honestly, to see how much it takes to pull off, a single game, at least from the medical perspective, and all the things that are happening behind the scenes, starting hours before the game begins and going on until everyone far beyond the time that people have left the stadium. So. The operational aspect of it, I think, has been the most interesting. So right now, I'm probably only certified in Washington. I think my Massachusetts license has recently expired, and I may sort of bring that back to life if I decide to go and cover more sports events in Massachusetts. But typically, positions are only covered in one state, and that involves essentially lots of paperwork, proving that you are practicing safe and you don't have any lawsuits pending and you haven't done anything crazy in your practice, and certifying your education. And so it's a fairly straightforward process. It's just time consuming because there are probably 50 pages that we have to fill out. I think that realistically you have to just accept that they are going to overlap and they'll run into one another, and you'll be doing research while you should be doing clinical work and vice versa, or sometimes often simultaneously. So I'm lucky enough that I've got some protected time to do my research, which means that it's a part of my work profile that I am able to put this specific time aside, and I don't have to see patients during that time. But it's not always that way, and a lot of times it's kind of a nights and weekends endeavor. Did a big project working with a university in Italy and in Germany, along with our institutions in Boston. And I think it's fascinating. It's really difficult, actually, because there are different practice cultures and different resources depending on where you are. We happened to be in a group where there were 3 different primary languages spoken, and so even communicating sometimes in nuances of research can be a little bit challenging, and it requires more work, but it's really fun getting to know clinicians and scientists all over the world, and then even locally here, working with some folks, again, back in Boston that I'm working with now. I'm working in a study that I think has 32 sites all around the country right now, so getting to work with that group and meeting these names that I've sort of only seen in pictures and read about, that's really fun. So I think it's a great way to extend your network as well as extending your own reach. So the most recent example is I give a lecture to the University of Washington medical students as a part of their annual curriculum, and I also give a lecture to a larger group within the UW system of various professionals, nurses and therapists and allied health workers, and that lecture is on ableism. And ableism ableism, in particular in the medical community and the rehab community, and health equity. And the responses I've gotten from that have been really fulfilling, because it's a topic that we don't typically think about, I think, when we think about diversity and equity. But there is, probably as much ableism as there is any other ism out there, and even within our walls. And so I think getting a chance to educate my colleagues and the next generation of physicians is really an important part of what I do, and thereby advocating for the disabled community, because I'm telling my colleagues that these are the things you should go out and look for, and this is the way that you can use your own podium and your own power and your own influence to make things better for the very people that we are supposed to be serving. I have a healthy respect for the brain and neurosciences. I am excited about all the things that are on the horizon, because things are changing really every day and every week in the neurosciences in terms of what we know and ways that we can help people, particularly in the neurorecovery space. I find those things really, really exciting, and there are so many people interested in that space now, more than ever before, I think, because we have so many promising therapeutics and approaches and new ideas about how to approach disability and neurorecovery. So I think surprising to many maybe is that I think I have an inner handyman somewhere not so deep down. And so my creative outlet, honestly, is in building things and teaching myself how to do new things. And so these are typically around the house because it's what I enjoy. So how to rewire lighting, and how to build a bench for my daughter. And so I've always liked working with my hands. That's actually one reason I went into rehab medicine, is because I get to work with my hands. And so this is sort of a non-medical creative outlet for me, is fixing and building and creating things around the house, actually. So a little bit strange, but it's actually, it brings me great joy. And my peace comes from working in the dirt. So I love to garden, and that makes me feel very old when I say that. But there is data actually that shows that after people work in the dirt, work in their gardens, that there are physiologic changes that happen that are better for your well-being. So. Well, just that I hope, I think particularly for your generation and sort of this younger generation of future scientists and future community members and contributors to all the great things that will be happening on the horizon, that we want you to remember to check your sources. There is so much information out there about the neurosciences and how to improve that aspect or that aspect of your health, how to prevent one thing or another. And because of the internet, because of social media, for the digital generation that is coming up, to really check your sources. I tell my daughter that all the time, because there's so much information out there that it's difficult to know sometimes what's real and what's not.